Okay. So, good afternoon, everybody. Today, we'll be having a session on graft versus host disease, gut. So, graft versus host disease is potentially life-threatening complication of allogeneic stem cell transplantation. And generally, graft versus host disease affects three organs. One is gut. The other two are liver and skin. So, it can be either chronic GVHD or acute GVHD. Though I said that only three organs are affected, any organ can be affected with GVHD. It can be any organ because it's an inflammatory condition, so any organ can be affected. So, with this short introduction, I would like to call upon our today's presenter, Dr. Shantanu, who is a senior consultant pediatric hemato-oncology and bone marrow transplantation at Kokiraben Dhirubhai Ambani Hospital, Mumbai. So over to you, Dr. Shantanu Sen. You can take it forward. Thank you.
Thank you. Thank you. Thank you so much for that very kind introduction. Thank you, ISBMT, for making this possible. I'm actually very, very impressed with this. Let me just try and share my screen. Give me a couple of seconds. Okay. So today we're going to talk about gut versus host disease. And as I understand it, we are talking to patients and carers who are taking care of patients with this or might be thinking that they have a child or somebody. So it's kind of very good to know about it. So first thing, if we talk about, and this is kind of, yeah. So what is gut versus host disease? So if you break it down, well, what is graft versus host disease? So what we are doing in the transplant is that we take some cells from a donor and then we give it to the patient, the recipient. Now, sometimes what happens is that these cells, these life-saving cells that we are giving to the patient, rather than going and doing what they are meant to do, which is cure the patient and repopulate the blood cells, which we have wiped out with chemo, they turn around and start to attack the patient themselves. So it's like in a warrior friendly fire where the army, rather than fighting on the enemy, fights upon its own soldiers. It's like that. Or where you have a football team, which rather than going and scoring a goal against the opponent, turns around and does the same side goal. It's exactly like that, where these cells, which are supposed to be protecting, turns around and starts doing toxicity against the patient. Why does it happen? So it happens because these donor cells, these graft cells, by mistake, attack the own cells, the host cells, seeing it as foreign. It happens after a transplant, and it can happen after any kind of transplant, be it like a bone marrow transplant, cord transplant. Usually, when you have a transplant from a different donor, which we call an allogenic, not quite so much or almost not seen in autologous, where you have the stem cells from the same person. Uh, it is a complication. There's a manageable complication. We have treatment for this. It doesn't mean that it's a transplant failure. And very important, sometimes patients say, what is it? Was it a fault of mine? No, these are a complication that can happen at any point. As we talked about, that there are two types of graft versus host disease. One is acute. Acute meaning that it happens very quickly after the transplant and very typically by definition within the first 3 months or the first 100 days of the transplant. It can, as we heard, that it can affect many organs, but yes, the one that we are going to focus on today is the stomach, the intestine, which we call the gut. So acute is the more common. So when you have an acute GVHD, mostly it is gut GVHD that it presents, and it can be quite often. You might have some more severe symptoms initially, and then they can actually come under control. Whereas the chronic part, it happens after 100 days, and it can affect the, sorry, I'm just going to reduce something for a second. Yeah, it can affect the gut, but the gut is less. More commonly, it's more on the skin, sometimes on the mouth. Now with chronic GVHD, these symptoms can be persistent, can last for a long time, need a lot of more management, more treatment. Very often, it can be difficult because these symptoms can almost be like where the body turns around and have an autoimmune disease. This can be something very similar to that. So you can have acute, chronic, acute gut GVHD and chronic, depending upon whether it's in the first 3 months or later. How common is it? It is common that if you look at GVHD, graft versus host disease, anywhere between 30 to 70% of all patients will have some degree of GVHD. Many of them will be very mild, not needing much treatment, might be just a little bit of support and will get better. And yet others might have a much more severe variety of it. And if you look at the entire spectrum of GVHD, graft versus host disease, the stomach and the intestine, the gut is one of the most common forms. And if we look at acute GVHD, 30 to 40% would be the gut would be affected. But if you look at chronic, the longer term ones, there more than 50% of all patients would have a gut GVHD. What are the factors that causes gut GVHD? Now, I have to say something. GVHD doesn't always mean it's a bad thing, because when we are doing a transplant for a malignancy, we want the cells to come in. They should also do a little more extra work, which is fight against the cancer cells, the malignant cells, which is called graft versus leukemia effect. But sometimes, rather than fighting against the cancer cells, in those cases, can fight against themselves. And that is what we try to prevent and try to cure as much as we can. So what are the factors? We know that when the patient and the donor is not perfectly matched, then we have more GVHD happening. What do we mean by perfectly matched? Whenever we try and find a donor for our patient, we would usually look for a brother or a sister who's 100% matched. But sometimes we may not have a 100% match, in which case, and which we do nowadays quite a lot, we do a 50% match patients. And certainly when that happens, we know that our GVHD rates will be a little bit higher. We know age is a factor. Older the patient, older the donor, it will go up. And certainly, if somebody has had a degree of GVHD before, then we know that they will possibly have higher risk. It also depends from where we are getting the stem cells. We can sometimes, and we do collect stem cells from the bone marrow, but nowadays many units, they collect stem cells from the peripheral blood because it's easier, and sometimes we have earlier donor engraftment. But like everything we do, there is a positive and negative. And we know that when we use peripheral blood stem cells, then the GVHD rates also goes up a little bit more than if we use a bone marrow. So as we said, that it also depends what kind of transplant that we do. And this is what I talked about when I said about how good the patient's match with the donor is. And as we said that if you have a 100% match, it's less. But if you don't have a 100% match in the family, and we are trying to find a donor who's outside the family, which is what we call a matched unrelated donor, you might know it as a donor that is coming from a registry, like a donor that's in the Datri registry or in the DKMS registry. Now that registry donor, that Datri or DKMS donor may be 100% match, but still because there are some differences, we know that when we take a registry donor, the GVHD rates will be higher. The lowest rate will be if there is a brother or a sister who's 100% match. It also depends what is the conditioning regimen that we use. What do I mean by conditioning regimen? You know that when we do a transplant, we first have to wipe out the patient's own bone marrow with either chemotherapy or radiotherapy. And that is what the medicines we call the conditioning regimen. Now, the more intense, the more aggressive, the more powerful the conditioning regimen, the more powerful the medicines that we use to wipe out the bone marrow, the more increased is the risk of GVHD. Also, when we use radiation as part of the conditioning chemo, if you use a total body radiation, And sometimes we need that if we are trying to fight a very aggressive cancer. But the more intense it is, we know GVHD rates also goes up. So it's always a balancing act between how much treatment we have to give to get rid of the body with the cancer cells that are there versus whether that will cause more GVHD. Other factors is that it also depends upon how is the patient's condition before they come into the transplant. Say, for example, if somebody already has a gut problem like Crohn's disease or something, then also we know that gut is already damaged due to the illness, and then GVH rates will go up again. So what exactly happens? So these cells that are coming in, these donor cells, they will go and target the lining of the stomach, the small intestine, and large intestine. And there are some specific cells called T cells which goes and does that. And what it does, it causes damage to the lining of the entire tissues of the stomach. It can cause damage to the cells in the mouth, the throat, the stomach, and down to the intestine. And with that damage, what happens is that if it's damaging the upper part, the patients feel that they don't want to eat, they lose their appetite. Lower down, you can have like absorption of nutrients gets affected, the food doesn't get absorbed very well, and you start having diarrhea. But it is to say that this gut GVHD can affect the entire part of the stomach, starting from the mouth down to the end at all. And what happens? All of these cells, the donor cells, because they cause the damage, it kind of destroys the lining of the cells, lining of the stomach, lining of the small intestine. And this triggers, like when you have any damage anywhere, you have the body trying to repair it. And in this case, the repair mechanism can sometimes go off and it causes yet more damage. The extent of the damage that it caused, the extent of the severity can be variable. Some might have very mild symptoms, like you might have a mild acute or upper gut GVHD where you just don't feel like eating a lot, or you might have just a little bit of a diarrhea, or it can be much more severe where patients can have a lot more symptoms, and I'll come to that. So what are the symptoms? So as I was saying, the symptoms usually are that usual symptom is diarrhea, and it can be having a lot of watery diarrhea, sometimes bloody diarrhea. And the amount of diarrhea can be a lot, I mean, going up to even up to 2 liters in cases. Patients usually have tummy pain, which is cramping, which is uncomfortable, which is severe. And in some cases, it can last for hours and hours. And sometimes we struggle to control it because it just keeps on happening. As we said, you can have loss of appetite. Patients doesn't feel like eating because they don't want to eat at all. And of course, that will cause weight loss. And then you can have heartburn, swallowing difficulties. So even if you want to eat, you find it really difficult, and that can happen in chronic GVHD. Sorry, somehow my slides are. Okay, so symptoms, as I said, that if the mild to moderate, you have nausea, vomiting, loss of appetite, a little bit of diarrhea, which is greenish, and weight loss. But with very severe gut GVHD, you can have frank bloody diarrhea that's just going out, which can be blood itself or can be old blood, looks like coffee grounds. Patients can have very severe tummy pain, need a lot of medicines to control it. They can't eat, they can't drink, they get dehydrated, they have malnutrition, and we have to support them through it all to try and get them better. So how do we diagnose GVHD? How do we diagnose gut GVHD? How do we confirm it? The first part is symptoms. If you have done a transplant and the symptoms we talked about, if a patient has this, then our radar antennas goes up, we start thinking, is this GVHD? But just having the symptoms is not enough. We will need to confirm it. And the first test is usually we rule out any infections, and that's usually a stool test and easy to do. But the real way to actually diagnose is to actually have a tissue diagnosis or an endoscopy. And the endoscopy needs to be an endoscopy of both the upper gut and the lower gut. And we do a tissue biopsy of that. And that tissue biopsy shows us and confirms whether it's GVHD or not. And that's very important because all the treatment that you would do after that, we'll need to look at that first tissue biopsy to confirm that that's what it is. So what's the treatment that we use? The first line of treatment is usually steroids, and that's used to control the symptoms. And many a time, just steroids itself might be enough. It may not even be steroids that are given through an injection, but steroids that are given as a capsule to actually just coat the inner gut and not get absorbed might be enough. And then we have second line and third line treatment as well, should the steroids itself not be enough. But it's also kind of important, not just thinking of medicine, but making sure that the patient does not get dehydrated. So we need IV fluids, and sometimes we might even have to give them all the nutrition through the veins, something called total parenteral nutrition. There are lots of other treatments as well. Sometimes, as we said, that if steroids are not enough, then nowadays we use newer drugs called Jakavi, etc., which have actually been very life-saving to a lot of our patients. Others, in cases that both the first line and second line therapies, and there are third line medications as well that we use, if they don't work, then we have other ways of treating. There is something called ECP, extracorporeal photophoresis, which may be used. There are experimental stem cell therapies you can use. And all of that, it's together with supportive treatment, like making sure that patients we give antidiarrheals so that they don't lose so much water. We actively look at pain management, IV fluids, and nutrition. I'm deliberately not talking about the medicines that much. What I want to say is that there is therapies and we have new therapies that are coming on each and every year. And even this year, we had a new treatment coming in, which means that nowadays, with every year that we have newer ways and better ways to treat patients. So don't lose hope. If you have a loved one who has GVHD, we probably would have a new drug and a better way to treat. But treating gut GVHD is not just medications, there's a lot of other things. And these are the things that patients, parents, carers can help with. We need diet modification. That whenever we give diet to the patient, it should be a little bit of a low fiber, bland diet. We try to avoid spicy food, we try to avoid dairy food because sometimes patients can have a transient lactose intolerance and they may not tolerate milk and milk products at all. So it's quite important to have small meals given more frequently that doesn't cause too much distension, that's easily digested, and a good dietitian and a nutritionist would be very good in this regard. Important to drink plenty of fluids. ORS is quite good to stay hydrated. Really important, listen to your medical team. Take the medicines exactly as they have said at the right times, and that's the best thing you can do. We need to track how much diarrhea there is, has there been weight loss, what the degree of pain, and all of these symptoms, the patient, the carers, the parents need to tell us, the medical team, so that we can give the support that your patients need. And it's very important to actually connect to other patients, other families who have a loved one going through this, so you can talk to each other and support each other through this whole process. If after the hospital stay you're managing gut GVHD at home, just remember those things that really hydration is important. Lots of fluids, frequent sips of water, ORS, lighter, clear broths and soups. Make sure you have good mouth care. Use a soft brush to brush your teeth. Make sure that if you have mouth sores, you kind of see your doctor urgently, see them, work with the healthcare team, your medical team to kind of see what works for you if you have pain. Maintaining hygiene is important and talk to your medical team for whatever symptoms you have so that those can be managed. I talked about how nutrition is very important. Bland, low fiber foods. You can think of well cooked vegetables like carrots, green beans, bananas, white rice is good. Low fat food. Avoid high fatty foods, which can cause more discomfort. You can have non-veg, but kind of bland baked chicken or fish is good. No milk and small frequent meals. And like we said, for very severe cases, we might have to go down for nutrients that are given directly into the veins, something we call parenteral nutrition. Sometimes we have patients who really cannot tolerate, and for them, we even pass a tube like a nasogastric tube in the tummy and deliver food directly so that we can manage to continue with nutrition for some patients. So, what are the key messages and takeaways for the future? And I want to say is that gut GVHD, it is a serious condition. I won't pretend otherwise. And certainly that if you have a disease that is steroid resistant, we all worry about those patients a lot. But it's manageable. It's common, it's treatable. You should never lose hope. Very important to try and detect it as early as possible and ensure treatment is started very, very quickly. We aim the treatment depending upon the symptoms. We might have to change the treatment and get on top of the symptoms. There's a lot of research happening in this field. And like I said, newer therapies are coming on almost every year. Some of those might be expensive, but they are getting better, and we are able to provide these newer therapies to our patients. And it's really important to work very closely with your medical team, seek support in the community, with the professional community around you, with the patient community, so you guys can all work together and we go where we are, which is treating our patients to the best of our ability and curing them. Don't hesitate to ask questions, and any new symptoms, you must report it. That's what I wanted to say. So thank you so much for listening to me, and I'm happy to take any questions.
Hello.
Hi.
Hello. Yes, yes. A very nice, concise talk on gut GVHD. As Dr. Shantanu said, it is a complicated thing in the sense grade 1, grade 2, or steroid sensitive GVHD, gut GVHD is a good thing, but steroid refractory GVHD is a nightmare for all transplanters. And one more thing, what he pointed out very well was picking up gut GVHD at early stage and treating it as early as possible. And dietary things, what Dr. Shantanu said was one has to remember that light food, avoid fatty diet, and even non-vegetarian food can be taken, but it should be bland. This was my summary about the talk. I am not getting any questions on QA point. And anybody has any questions? Feel free to ask those questions to Dr. Shantanu.
Thank you so much. Thank you.
Yeah. So as there are no questions, thank you very much, Dr. Shantanu, for the nice talk on gut GVHD. I am sure that this will help patients and their relatives in understanding gut GVHD, which is a horrendous complication of allogenic stem cell transplantation, especially if it is steroid refractory.
Absolutely.
So we close this session, and I again thank Dr. Shantanu for his excellent talk. We will move on to our next session, which will be conducted by Riya Daruwala. So, Dr. Riya Daruwala is a consultant psycho-oncologist at Muzumdar Shaw Medical Center, Narayan Health City, Bangalore. And she will be conducting the next session with her panelists. Over to you, Dr. Riya Daruwala.
Thank you, Dr. Abhijit.
Yeah.
I'd like to first welcome our four panelists. So our first panelist is Teresa Chinchu, who's the nursing officer at our BMT unit at Narayana Health City in Bangalore. Our second panelist is Dr. Sri Priya Venkateshwaran, who's the head of content at CICN Cuddles Foundation based in Mumbai. We then have Ms. Nandini Subramaniam, who's a pediatric BMT dietitian at Apollo Cancer Center in Chennai. And our last panelist is Ms. Shania Kinney, who's a journalism grad. She's a foodie, a crossword solver, and a GVHD survivor, relearning to eat after her transplant. So thank you for being here. I'll share my screen so we can get started. Can you see my screen?
Just put it full screen.
Yeah.
Yes.
Fine. Okay. So my first question is to Sister Teresa, who's a nurse in the BMT unit. Sister, from your nursing experience, what are the most common nutritional challenges that you see in patients with gut GVHD?
Okay, thank you, Dr. Ria Garwala. Thank you for the opportunity to present this. Actually, patients with gut GVHD face significant nutritional challenges due to both the disease process and its treatment. The most common nutritional challenges seen in these patients are like severe malabsorptions will be there. Why? Because of the GVHD, it often causes inflammation and ulceration of the mucosal lining that impairs the nutrient absorption. So patients may experience weight loss, fatigue, and the signs of nutrient deficiencies. So the second thing is like profuse diarrhea will be there. Just like a large volume of motions they will pass. Because of that, they will have it can lead to fluid and electrolyte imbalance, like further complicating for nutritional intake and increased risk of dehydrations will be there. So the next thing is like poor oral intake will be there. Why? Due to nausea and vomiting, with some abdominal pain or cramping, sometimes mucositis, some taste changes also will be there. So in that time, patient may refuse food or eat very little food, requiring close monitoring of intake. Then increased metabolic demands will be there. Why? Because the amount of food what they will take is very less, and the energy they consume is very more. The calories it will require is more. So the next thing is like dependence on parental nutrition. So many patients with moderate to severe gut GVHD cannot tolerate enteral nutrition due to the diarrhea or absorption issues. So close monitoring for central line infections. So TPN complications like hypoglycemia, liver function abnormalities will be there. Sometimes food aversion and psychological impacts, long hospital stay or repeated nausea, vomiting, and emotional trauma related to eating and other symptoms. So in this time, patient may show food aversions like depression or anxiety. That time we require to support them with the emotional supports. Some medicational side effects are there, like immunosuppressants which they receive, and antibiotics that also will alter the gut flora and the appetite. So steroids can cause increased appetite, but still it lead to catabolism. So as a nurse, our challenges like daily checking of weight, intake output monitoring, nutritional consult and dietitianal involvement, then electrolytes and lab monitoring, all these things will be there.
Thank you, sister, for that very well described answer. Moving on to our next question. This is for Dr. Shri Priya. Could you explain how the food we eat can help the gut heal when someone has gut GVHD?
Thank you, Ria, for this question, and I thank ISBMT for this opportunity. So the role of food and how it actually helps the gut is something which is, I think, Dr. Shantanu has touched upon it very beautifully. And I just wanted to say that during gut GVHD, food can either heal, and it's important to remember food can either heal or it can actually harm. And this, what role a food plays depends on the stage of the GVHD. So typically, in when you have the severe cases, where stage 3 or stage 4, wherein there is a lot of bloody diarrhea, there is more than 2 liters of diarrhea, and there is a lot of stomach pain, and the child is having nausea. At that point of time, in fact, not giving food will be better, and that's when we actually rely on TPN, and that actually helps, gives the gut a break, helps it heal. And then as we slowly the child's symptoms improve is when we start introducing foods which is like very basic food which is not having much of fiber, which is low in lactose, and which is low in acid, like things like nimbu, or not giving things like oranges, not things which are very sour. These foods actually helps. These sometimes act as triggers, so that's when they start actually harming. So food is something, as I mentioned, it can heal or it can harm, and that's the way it helps. And so a nutritionist being involved in going through these different, it's usually a 5-phase diet is what is typically mentioned for a GVHD, for gut GVHD. So going through these phases actually becomes very important for patients to actually recover.
Thank you, Dr. Shripriya, for that. Our next question is to Ms. Nandini, who's a clinical dietitian. Ms. Nandini, in your clinical practice, what are your top priorities when you are planning diets for patients who have gut GVHD?
Yeah, good evening to everyone. Thank you for ISBMT for giving me chances. So first thing, as far as GVHD concern, first we'll discuss with our medical team. There are two main principles in gut GVHD. Main thing, hypoallergenic diet and the small frequent meals. So first we'll see the patient loose stools volumes. If that the loose motion volume is less than 1000 ml, so we'll give it the parental nutrition with partial enteral also. We'll just start on it like a traffic feed. Initially, we'll just start with 3 to 5 ml. How patient gets tolerated, slowly we'll just increase the ml. If the loose stools is larger volume, about 1000 ml, so patient might not need for oral. There is no enteral feeds. Only parental nutrition will just give on it. The main diet is, as I said, low fiber and low fat diet. We'll just focus on it. Then due to loose stools, we know all macro and micronutrient loss also will be there. So weekly once we'll give the trace elements, salicylate and the multivitamins and the thiamine all also will given for the patients. So we'll just see the patient loose stools thing, then slowly we'll initiate on the oral diet, mostly preferable parental nutrition.
Right. Thank you. Shania, looking back, what was the most difficult part about eating or nutrition when you were going through your gut GVHD journey?
Good afternoon. Thank you so much for having me. Well, the most difficult part was the fact that I wasn't allowed to eat. And as my bio says, I'm a foodie and I really like to eat. And so to let my gut heal, the Hope team decided to insert the NG tube and restricted oral intake. So the only nutrition I had essentially was through the TPN bag. And then eventually, in a few days, we started on Encipro Gold. It took a while for my gut to heal and to get slightly better, and only then was I allowed to eat. As I mentioned, it was very difficult for me, especially because it was eat time, and I don't know if you guys are from Bombay, but it was Mama Dadi road season at the time. And you go on Instagram and every second person is talking about Mama Daji Road, and it just gave me a massive FOMO.
Thanks, Shania, for sharing that. Sister, how does you and your team generally manage feeding difficulties? For example, when patients struggle with nausea or diarrhea or mouth ulcers, what do you do as the nursing team to help them?
Actually, the patient with GVHD, maximum it is like with nausea and vomiting means like nurses, they have the team will play a vital role in identifying issues early. So early, if we identify, we can just implement targeted interventions and facilitating the interdisciplinary care to optimize nutrition and comfort for patients with severe GI complications, like managing nausea or poor oral intake means small and frequent or bland foods we will provide for them. At a time, if they take a large amount of food, it will be difficult for them. Like when they have the symptoms like nausea and vomiting. So we will advise them to take small and frequent. So then with the diarrhea, like fluid and electrolyte support will be provided, ensuring oral rehydration solution or IV fluids, closely monitoring of intake output, vitals, daily weights, and lab reports, which will give the imbalances with the electrolytes or any other things. Then handling mouth ulcers. This is very important, like using of specific mouthwashes and local pain relief also should be given to the patient to get relief from that. So, internal or parenteral support, if oral intake remains inadequate, so internal feeding by NG tube. So, NG tube is preferred if the gut functions and the oral intake is insufficient. So, total parenteral nutrition should be considered for severe GI dysfunctions while monitoring for complications like infections, hyperglycemia, and liver issues. The challenges with nausea is like small meals we have to give. Sometimes they will be like having more appetite, and we tell them to take very small amount of food. No, they will be like agitated with that. And with the diarrhea, like rehydration has to be given, bland diet will be given. We have to advise them to like avoid spicy foods, or what they like, we have to tell them to avoid that maximum to prevent the further complications. And collaborative and supportive care is necessary.
Thank you, sister. Circling back to you, Dr. Sripriya, do you think that there are certain nutrients or types of food that can help reducing gut irritation and help recovery sooner? I know you covered this very briefly in your previous answer, but if you could elaborate, that would be great.
Yeah. So I think I'm not going to talk about the foods because I think that's kind of a recurring theme that all of us have actually gone through it, right? I mean, all of us in this talk have mentioned something or the other thing. But I would like to mention two specific nutrients, which is basically like glutamine is an important thing that I feel which we really need to focus on. And the other thing is about prebiotics. So the first thing is, energy and protein and those things. I think Nandini also covered, saying those are required micronutrients, macronutrients. But specifically, the role of glutamine, if you look at it, is glutamine is a non-essential amino acid. Yet, what happens is during stress, the requirements of this particular, non-essential amino acid becomes more important. And glutamine actually is important also for the intestinal cells to actually regenerate, to grow. And I think there have been few studies, there have been a Cochrane, meta-analysis that actually has shown that glutamine does help in helping the intestinal cells recover and proliferate, and it can actually help in GVHD. So that's one, a nutrient that I would really would like to focus on. The second thing is basically prebiotics, not probiotics, because prebiotics is basically any fermentable fibers. Now we did speak about giving something which is of low fiber. So when we are looking at, so fiber is of two different types, right? You could have like soluble fibers and you can have insoluble fibers. Typically, it's the insoluble fibers which you kind of probably find in like these peels of skins, and then whole wheat and whole grains is when that actually becomes an irritant. But you have soluble fibers like the ones that you get probably in apples, peeled apples, or like even raw banana, boiled raw banana. These actually have fermentable fibers that is actually acted upon by the microbiome. So we keep talking about the gut, and we keep talking about the cell lining, but we don't really talk about the most important, population, which is the microbiome, because that actually has a role in immunity. It has a role in, like, say, ensuring that the tight junctions, are which actually prevents translocation of pathogenic bacteria from the gut or the food that we eat into the blood. It actually helps in a whole lot of intestinal health. So I think we also need, while we are focusing on providing the children with the bland diet, incorporating these kinds of soluble fibers that actually helps in formation of short chain fatty acids, or like butyrate. That's one of the short chain fatty acids, which is actually the energy on which these intestinal cells thrive. So I think that's something that I would really like to focus on. So glutamine and prebiotics would be my nutrients or nutrients of choice.
Thank you. Thanks, Shripriya. Ms. Nandini, how do you practically adapt diets during different stages of GVHD? For example, an acute GVHD flare versus recovery.
Yes. For example, if in acute condition, first we'll based on the loose stool volumes. If it is loose stools are larger, we will get patient on nil per oral. So we'll give only the parenteral nutrition. Then slowly we'll start on partial enteral nutrition like traffic feed, as we said, no, the traffic feed in the hypoallergenic formula like elemental formula will given for the patients. Then during the recovery stage, we'll just initially start with clear liquids. For example, coconut water and the rice kanji, some clear dal soup. Like the clear liquids, we'll just start with 10 ml, 20 ml. How patients are tolerating, slowly will increase the ml. The main thing basically, we won't give any juices because the sugar content, it will again increase the osmolarity diarrhea. So we'll start with only the coconut water, rice kanji and clear soups. How they tolerated will increase the pace. Then slowly the loose stools has been recovered. Then we'll start with some mashed diet. Like for example, khichdi, dal rice and the curd rice, mashed pumpkin and mashed potato. Like that smashed diet will just start morning. Then along with this, if patient tolerating, we'll start with some protein powders also. Nowadays, the protein drinks will be available in the liquid form also. So depends on how they are tolerating, we'll advise for the patients. Depends on their calorie protein requirement, how much they are taking. Along with that, we'll advise some protein liquids also. Then we'll follow up with the patients. If they tolerating, slowly they will start on with the regular normal diets.
Right. Thank you. Shania, during your journey, were there any foods, drinks, or even routines that made you feel more comfortable and nourished despite all the challenges you were facing?
Yeah, sure. Well, the first few weeks of eating were very drab. It was only like mashed potatoes, kanji, stewed apple, khichdi, and then eventually curd rice. Um, so because I was very weak, I had lost a lot of weight and I had swelling in my feet due to lack of protein. So then Dr. Revati tried to introduce beef. So I was very happy about that. Um, with my diet, while slowly introducing a lot of things, it was a lot of trial error. So for the first few weeks, I'd be eating only rava sheera for breakfast because it was filling and easy to digest. For lunch, I would have like khichdi or curd rice along with like some vegetable. Um, and for dinner would be the lightest meal of the day. So I'd have like chicken broth. So bone broth really helped me for the next couple of weeks. And then later, it was berry season at the time, so blueberries and strawberries, along with yogurts, so smoothies. So and then the thing is, I'd walk around the house a little bit to aid digestion. But I mean, I'd still end up throwing up every night anyways for the first couple of months. Um, yeah, that is what I did.
Okay. Thank you for that. Sister, what advice would you give to caregivers to maintain hygiene and food safety when patients are immunocompromised and have gut GVHD?
Actually, with these problems, no, they have to be very careful. The main thing is like hand hygiene and personal cleanliness. Hand hygiene, always wash hands thoroughly with soap and warm water. So before and after handling food, then after using the toilet, so touching any pets or anything, it is not, you think it's not clean. So main and major thing is like washing your hands properly. So then the second thing is like when you prepare a food, so just clean around the place where you prepare the food. So anything, one small thing also can make a difference, big difference. So because the all the lining inside the gut, everything is it is break, and the infection can enter into the bloodstream. So how much ever we will be careful and we are taking care, no, that much this complications also we can prevent. So like taking a bath daily, that also can lead, because it's usually we will tell in BMTU units like to not to wear any jewels on the hands like rings, bangles. Why we tell that means because to prevent bacterial accumulation. If anywhere in the rings we cannot see, because every day we are not removing it, so continuously we are wearing it. So anything got stuck in there somewhere here, and you are using your hands to cook the food, and it can cause some problem. So it can also lead for further complications. So hand hygiene is the main and important thing you have to follow.
Right. Thank you. Dr. Shripriya, so many families worry about giving the right food, and there are many new ideas or tips from research that can help parents feel more confident about what to feed their children or relative, because there's just so much information available, and not all of it is necessarily right.
Yeah, so actually we live in a time of like misinformation and too much information, and it does become a challenge. And I feel the way we actually, so let's look at like GVHD, right? So as Dr. Shantanu had started, right, you have chronic GVHD and you have acute GVHD. And typically, if you look at it, the probably the acute GVHD, because it's happening closer to the transplant days, they would still be actually having being in touch with the nutritionist. The nutritionist is there to guide them. So then, what happens is there is a lot of things that the parent can actually ask, and and he or she would actually get the suitable directions or recommendations. But when you have chronic GVHD and it is like happening, much for a longer period of time, I think my recommendations is for that particular class. I would say that start. So as you know, like Shania was also saying, right? I mean, she's been a foodie, and so obviously you're going to be ending up trying a lot of new dishes that you've not really in your repertoire. So whenever you're trying those, I think I would say that start it slow. Take a small sample of it, wait for like 3 to 4 hours and see how it works. So this way what happens is like you also understand the trigger foods. So then as every child or every patient is different, what works for you might not work for another. So so taking the information from the internet and directly incorporating it in your child or relative would not be the right solution. So it's about waiting and watching, seeing how it works, and taking things slowly. Again, the small meals, giving them the small meals, that would be something. Um, and that's what is actually would be the right food. What works for your child is the right food. And of course, I think the proof of the pudding is if you know that your child is gaining weight, your child is active, he's, if, they're able to concentrate well in school, you're doing the right thing. So I would just say that, trust the gut and look at the symptoms, like monitor for weight gain, monitor for any abdominal cramps, or monitor for any of the other symptoms that might show that the child is not, probably the particular food is not suiting the child.
Thank you. Thank you for that. Ms. Nandini, could you share a few examples of meals or feeding strategies that you have used in your practice, and that have worked well for your patients?
Yeah, yes. In our hospital setup, usually for the enteral feeds, we'll use the hypoallergenic complete elemental protein powders. That will work on very well the good results, like for example, Neocate and Osmosate and all will give for the patients. That will work on very well to the patients. If patient is on oral diet, we'll introduce that protein. It's available in the liquid form protein. So that also will helpful for increase her weight. Then other form, we are using raw banana powder. So it's coming in the powder form. So we'll just boil and mix it with the food. Like most of them are aware about that. That also given best result. And we are using MCT oil because as we all know, all the patients due to the diarrhea, weight loss will be there. So we are using MCT oil. Nowadays, MCT oil Pro, it's like a 50% of oil and 50% of water. So if patient might not tolerate the whole MCT oil, that will be helpful for the easily absorption and digestion also. That also very well work with for the weight gaining for we are using the patients. Then other thing, whenever we'll start the food for the patients, we'll start one new food only per day. Like if one day we'll start with khichdi means how it's they are tolerating as ma'am said, then we'll start the new food on the next day. Like that only. So major protein made liquids you can use it, and the protein supplements and the raw banana powder and all easily helpful for reducing these loose stools. Then in our hospital setup, if patient post transplant, they are getting discharge means they are staying in nearby our hospitals only. If they needed any foods, anything, they will come and get it from our hospital itself. So that things also we are having. So patients, they directly come to our kitchen, they will receiving the foods.
Okay. Thank you. Thank you for outlining that. Shania, if you had a message, what message would you like to give other patients who are currently struggling with eating during gut GVHD at this point in time?
Well, the first thing would be to take it easy. I remember being cranky in the hospital, just drooling over food on my phone and just wanting to eat something. And so the first morsel of the very terrible hospital food, dal chawal, felt like ambrosia of sorts. One message would be, well, take it easy, be patient, things will settle. It may take a while. It's going to be hellish, but don't give up hope. And I cannot wait to be vaccinated and get McDonald's.
Thank you, Shania. So I'd like to, kind of run this by all of you in turns, if that's okay. Starting with Sister Teresa. So, would you like to share one practical takeaway for patients and families to help manage their nutrition during gut GVHD? Something that hasn't been covered yet.
This actually eat small, frequent meals. Don't take large amount of meals at a time, and choose easy to digest food. Then raw vegetables, which are the foods to avoid is like raw vegetables, fruits, then spicy food or high fiber or fried foods to be avoided. Dairy, if lactose intolerance is there, means it should be avoided. So best options like whatever the dietitian, whatever the healthcare team asks you to maintain that properly. Then only you can have a better health. And if you have a better health, then you can have it more later. First, you have to get your health proper. Then you can have whatever you require later.
Thanks, Miss Nandini.
Main thing, as sister said, small frequent meals will be fine. Then if patient have any lactose intolerance, nowadays that lactose free milk also it's advisable. Then don't take how we are saying, don't at a stitch, don't take too much new foods and all, don't initiate. Slowly you can start your diet, that will be helpful on it. Then later phase, you can have a regular normal diet. Everything it should be well cooked, proper hygiene.
Thank you, Shripriya.
I think this is like, sometimes when a nutritionist is seeing, like, your diet might change every 3 days or every 4 days. And I think it's just not because of that she's changing her mind, but it's because she's matching the symptoms with what the diet has been given. So I think, I'm resonating what like Shania was saying, right? Have patience and trust the medical team and the nutritionist that they are matching the diet with your symptoms. So she's not changing her mind, she's actually trying to tailor make the diet for you. So have
Thank you.
patience.
Shania?
As everyone said, just be patient, trust your medical team and listen to them.
Thank you. So with that, we come to the end of this panel discussion. I'd like to hand over to Dr. Abhijit to take it from here.
Hello. Hello.
Yes, Dr. Abhijit, you can hear
Yeah,
you.
yeah. It was excellent moderation by Ria Daruwala madam, and lot of insights regarding gut GVHD and overall management, and especially the patient's inputs were fantastic because that gave us an idea about how we should go about gut GVHD. What she said was appropriate. That be patient and just continue with the treatment. Be patient and believe in yourself. That was a great thing because it's very difficult time for the patient when he's going through GVHD, especially gut GVHD, which is not responding to chemotherapy, to the drug therapy. So I would like to thank both Dr. Ria Daruwala madam as well as Dr. Shantanu Sen. There are few questions, so I would like to discuss those questions. Just a minute. There are 4 questions. Dr. Shantanu is around. Dr. Shantanu. Okay, fine. I don't think he is there. Mr. Chetan Gotilkar has asked one question. In case of haplo 6/10 match T depletion transplant, how common is gut GVHD? The answer to this question, I will answer this question. Gut GVHD is more common in haplo transplants compared to matched sibling or matched donor transplant. I would say about 10 to 15% more than complete match transplants. This would be the answer. The second question, I think, uh, one second. Okay, second question, I don't have the answer to this question. I think one of Dr. Daruwala madam can answer this. Is hydrocortisone enema useful in gut GVHD? Have you ever given this?
Dr. Abhijit, I may not be the right person. I think Dr. Revati is
Okay,
here.
Dr.
I think she
Revati
would be
madam,
the best
can you
person.
chip in? Hello? Hello?
Yeah, give me a minute. I'm just
Yes,
looking at the
madam. Okay, madam.
question.
Sorry.
We generally avoid enemas in gut GVHD because it increases the risk of bacterial infection. So we try not to use enemas. Whatever we can do orally is what we try.
Okay, sure. Uh, okay, a few other questions are not relevant to gut GVHD, so we will not take those questions. So with this, I will summarize the session. It was a fantastic session and nicely summarized basic pathophysiology and clinical manifestation of gut GVHD by Dr. Sen, and then the discussion on nutrition during gut GVHD. With this, we'll close the session, and the next session, it is generally the second Saturday of month, but as second Saturday falls on Raksha Bandhan, we will be shifting that to one second.
Abhijit, the one question that is there in the chat box about patients having GVHD after they have gone home or it is late gut GVHD, who will be in charge? Who will guide them? Because they've come away from the transplant unit.
Yeah.
I think the primary team should make a decision and work with the local team. And I
Yeah.
think we can ask Ria to add a little bit of the impact of GVHD on the mental health of a patient and their family. Ria, please sum up the session.
Thanks, ma'am, for that. I think that's a very important question and something that we often struggle with because compared to most other forms of GVHD, I think gut GVHD can be extremely emotionally distressing, not just for patients but even for caregivers. Food just as a form of care or nourishment in cultures, especially like us, is extremely important. And when we take that ability for caregivers to do that, there is often a lot of sense of hopelessness, helplessness, sometimes even guilt that they're not even able to eat. Like it's possibly the most basic need that we as humans have, and I think Shania highlighted that very aptly. So when we see patients with gut GVHD, a lot of our time is spent, in trying to help them understand what Shripriya was highlighting, that food is not always helpful. It can also be harmful, which is sometimes very difficult for people to understand. So psychologically, gut GVHD can be extremely difficult to deal with, because it's one of our, like I said, most basic needs, and they require extensive emotional support during this journey, because even one lapse can set us back medically a lot. So sometimes parents may feel that there's no harm in giving a child one momo or one ice cream, right? But when weeks and months of work have gone into reaching this point of recovery, even that one morsel of food could set us back. So a lot of support from psychosocial teams helps you kind of navigate this journey slightly more emotion. I mean, slightly better, I would say, as compared to not having a support system. Thanks, ma'am, for highlighting that part as well.
तसं नाही दाखवत. टेक केअर वरतीच दाखवते. बोलतो त्यांच्याशी. ओके. हॅलो. हॅलो. Okay, we'll leave. We'll sum up this session. Thank you. Hello.
Yes, sir, we can hear.
Hello. Yeah. Niroji, so we'll sum up this session. Thank you very much. The next will be on 3rd of August, right? 2nd of August or 3rd of August.
2nd August.
2nd August. Yeah. Thank you. Okay then.